In this video, I'll try to explain to you the kind of challenges that you are likely to face when you have a patient with a cataract as well as an associated asteroid hyalosis. Visualization during the surgical procedure, especially during the irrigation aspiration, is enhanced with the help of the red glow. Now, this is something we need to always keep in mind and never take for granted. In this video, it's quite clearly depicted how the presence of a significant asteroid hyalosis causes significant disturbances in the visual acuity, especially while performing the irrigation aspiration. The most important message of this surgery is that remember that at all points during the surgery, remember to always be focused at that level at which you're operating. Once you get to almost to the end of nucleus management, these asteroid hyalosis can cause significant visual disturbances, and you got to be mindful of this fact. Let's move to seeing the surgery. Here's a patient who presented to us with a grade 2 nuclear sclerosis with a suspected polar cataract and significant asteroid hyalosis. So even before I start the surgery, I'd like to visualize and see what is the extent of the asteroid hyalosis to be able to anticipate the kind of visual obscuration or the visual compromise it may cause during the surgical procedure. Having done that, I then move to starting the surgery. So the initial steps of your incision, your rexus, your hydro remain pretty unchanged. As I always say, and I'm happy to repeat here, that there should be no compromise in your incision creation, in your hydrodissection and free rotation of the lens, as well as your capsular rexus. These are always the most important steps that dictate the way in which the rest of the surgery will go on. Now, this is a patient with a nuclear sclerosis grade 2 with a suspected polar cataract. Hence, I need to ensure that my rexus is not too large, something roughly about 5 to 5.5 millimeters. Having completed the rexus, I now go in with my hydrocannula, define the plane of injection and inject a jet of fluid to perform a hydrodelineation. I then proceed to the nucleus management. Now, 1, this is a really soft cataract. 2, there's a suspected polar element. So I work with really low flow settings, which is just enough to impale into the nucleus to create my chop and then to subsequently emulsify the fragments. A reduced flow rate to give me a little more control, as well as just adequate vacuum to perform the direct chop procedure. In this patient with the soft suspicious polar cataract, please notice how I'm performing a direct chop, but I'm performing a lateral separation in situ. What I try and do is create one fragment, bring it out, which then gives me the space to be able to turn the nucleus comfortably should I choose to, without affording adequate stress to the posterior capsule. Let's watch the rest of the nucleus emulsification. Now, as I mentioned earlier, up to the point of the nucleus disassembly and the nucleus emulsification, the asteroid hyalosis do not cause any visual obscurations during this part of the surgery. Also note that since this is a suspected polar cataract, I never let the chamber shallow. I perform a viscofluid exchange at each step. I then proceed to performing a viscodissection to loosen the epinuclear plate. I then proceed to removing the epinucleus with the phaco probe, but my power modulation is now changed to the settings of the epinucleus mode, which is a power not more than 5 or 10%, because you really do not require energy to do this. A very low flow rate, because at this point you're very close to the posterior capsule and you want things to happen slowly, and you need to have adequate and absolute control. And finally, with a minimum vacuum, just enough to aspirate the epinucleus. This is followed by the irrigation aspiration of the cortex, and for that I prefer to use the bimanual irrigation aspiration technique of cortex removal. Let's proceed to watch this part of the video. And as you can see, there's a fairly thick part of the epinucleus still retained within the eye, and an attempt is being made to remove it. Removal of the epinucleus with irrigation aspiration can take a little more time. Now it is at this point, at the onset of irrigation aspiration, where you can actually see the significant disturbances that these asteroid hyaloses can cause. Always be mindful while performing your irrigation aspiration to remain focused on the cortex that you're trying to aspirate. Now, the restial epinuclear cortical complex is still posing significant resistance to its removal. In order to aid this, therefore, what I do is I perform some more of a viscodissection to try and loosen it and bring it out into a zone where I can easily aspirate it. It is the removal of the last part of the cortical sheet, that is, the thin layer of the cortex that lines the residual anterior capsule and the posterior capsule, that I find particularly challenging when I have an associated asteroid hyalosis. The asteroid hyalosis can be visualized so much more clearly upon the removal of the cortex. I then proceed to the insertion of the IOL in the capsular bag. Make sure that when you are introducing the IOL, be mindful that you can clearly see your excess edge and that both the haptics actually do go within the capsular bag. This is followed by the removal of the excess viscoelastic and finally with the stromal hydration, which would then bring us to the end of the surgery. So to summarize, once in a while we are going to be faced with patients who present to us for a phacoemulsification surgery that have an associated asteroid hyalosis. And in such cases, we need to be aware of the fact that they can cause significant visual obscurations, especially at the time of performing the cortical wash. So be mindful, be completely focused, and understand that they are capable of limiting your red glow, thereby causing significant disturbances during your surgical procedure.